Today, we are setting up first of its kind a lab, a collaboration that's between academia and Sparsh Hospice to further research, reflection, and dialogue on death and dying. I would like to acknowledge two giants in this field. One is, of course, the Sparsh Hospice Center that has been working tirelessly for the past about 14 years. And I think the other part of the equation when we are setting up this lab is, of course, the Center for Social and Behavioral Change. Director is Professor Pawan Mamedi, who is here today to help us bring the behavioral insights and the academic rigor to bring evidence-based interventions. I truly believe that although we are signing the MOU with Ashoka University for this collaboration, I'm looking to reaching out to all of you to further this dialogue and conversation. With that, maybe we can start with the MOU signing. We have the folders and the documents, and Pravan and Dr. Subramaniam, if I can just invite you to do the honors and sign. Dr. Subramaniam, I can start with you since you are the pioneer for Sparsh and you helped set it up with some of your friends in Hyderabad, and again you coming from a medical profession, because generally end of life care or especially hospice care is looked at as a medical fallout from a medical thing, because maybe the idea is that we are giving up on the curative part of the medical side of a disease and going into palliative care. So if you can shed your light on how you got started with Sparsh and what has your experience been in this journey?
So basically I'm an anesthesia doctor, so we used to do intensive care practice, and we saw a lot of needless admissions into intensive care for patients who we knew were end of life, and there was no intermediary space. So it was either you be at home, or if there is a symptom, come to hospital, symptom deteriorates, you get onto a ventilator, and needlessly, for a few days your life is prolonged and you die. So this was not only wasteful, I mean there is a huge expenditure in intensive care, and the patient is deprived of his relatives to be around him or her. So this was something which was playing on a lot of our minds, that we should provide an alternative way of making the end a little more aesthetic. So I think that's the basis of how it started.
And maybe like you said, I think this is something that we all see in our day-to-day life is when like there's a little bit of a distrust in the medical profession when it comes to the end of life care, right? And we think that there's unnecessary interventions and the patient being held in ICUs. So maybe if you could shed some light in terms of some of the systemic barriers that you feel is from a person's perspective to embrace palliative care.
The laws in India were a little rigid, that if a patient went into the intensive care and he was put on a ventilator, even if you knew that the treatment is hopeless, you could not ask for disconnection and taking the patient home. Disconnection would mean that patient will die in many situations. There was no legal framework to make this happen. And the only way someone could do it is to say, I am leaving against medical advice, which is a little, roundabout way of doing things. So, right now, I think one landmark in this was, there was a patient called Aruna Shanbach. She happened to be a nurse in Tata Memorial Hospital who got raped by some attendant in the hospital, and she was in a vegetative state for maybe 20 years or so. And then some good Samaritan went to the court and said, why are you prolonging her life? And it's taking up so much of resource. So the court said, yes, you have a point, but unfortunately you don't have a direct connect with this patient. You are no one to file this case. But they recognized the fact that you should not prolong life unnecessarily. So that was the first time Supreme Court has now put some guidelines how someone's life can end and how you can have an advance directive. So initially it was that you had to go to a magistrate and declare your will that I don't want to be on a ventilator or whatever it is, and he had to sign. But it's become simpler now. So I'm not following it so much. I think Dr. Raju knows a little more about that. But there are now guidelines for end of life. So we have evolved a lot from about 20 years ago.
That's great. And I have read about that legal framework that it's a little bit easier now with the end of life. And maybe one of the things to follow up, and Radhika, because you deal with patients in and out, right, and families, and how hard or how easy is it for families to accept this end of life care? I mean, now maybe it's easier from the medical perspective, but from an individual perspective, what do you find?
Hello everyone. It's as a care and caregiving and the grief here at hospice is really difficult for any family member to deal with. One patient come to Sharda Garu, our senior psychologist. She was like tears, crying like badly. She said, "I have 83-year-old husband at home who is terminally ill, cancer patient, and dementia. He's not recognizing her. At the same time, she doesn't want to institutionalize him here because she thinks like what other family members or outside people, they may judge me." So it is very difficult for the family members to accept the fact the family members are end of life care, but we just want to counsel them so well so that they can put the patient here. What I feel is, as a community, we need to develop support groups. That is very much needed. And like we, as Sparsh Hospice, as home care and in hospice care, we do a lot of bereavement support for up to 1 year. But that's not sufficient. Like it should come like within the community also. So that is what, like, as a behavioral lab, like we can, like when we go to the communities and explain about like these support groups, as like West in like US and UK, they have all these support groups, like definitely they share with each other, and that will definitely mitigate their pain.
I think it's a very important thing all of us should realize, that we feel we are shielding our loved ones by not giving them the information about a serious illness, especially cancer. So I think eventually the patient will come to know that there's something wrong with them, but they think they're doing a service by not telling. Whereas our team here believes that everyone has a choice to know their end and then plan what they want to do. So, and also not talking about end of life, as you said, leads to very unfortunate situations. I knew one case where a close family, the father was about 80 plus and he had dementia for 2 years before that. So he was, he used to walk around but wouldn't recognize anybody, anything. And he became bedridden with a stroke. And I told them, don't feed, tube feed. And they did the tube feed. 1 year he was in bed, feed used to go, motion and urine come out. And 1 year he was not awake, he was just breathing. So I don't see who we are benefiting by doing things like this. I mean, I'm sure if he was alive, he had a choice, he would say, I don't want this to be done. So I think a time has come where all of us should make our choices known.
I think that's brilliant. Thank you for that insight. And actually, that goes to Pawan now to you. How do we make this happen? So I think, like you said, patient autonomy is not here in India as much as, like Sharon, you just mentioned, right? Your parents have made these decisions and choices. And I remember just an incident. I was talking to my dad, and he's 80 plus, and he's a medical professional. And when I asked him, what do you want to be done? He said, no, the hospital will take care of it. You don't need to worry. He was not willing to even have a conversation. So, I think there are certain behavioral trends or maybe the way we as a society have evolved. So, Pawan, would love to hear from you as to what your thoughts are and how the Sparsh Behavioral Lab can, look into this deeply.
I just want to preface my few comments with this very famous lines by T.S. Eliot, the poet. All of us are actually dying, but with a little patience. So that's it's a profound line. Much like people do have a right to know when they're going to die, and that needs to be respected. People also have a right to grief, and we try to disable the right to grief. I'll give you an example. When I used to live in America, my mother would systematically conceal any information about people dying in my family. I want to, one deluste or Bhadavardtadu, that kind of a psychology, right? I mean, and she was, who was she to deny me that information?
That's exactly.
My right to grief is my right to grief, and it is as important as my right to pleasures, right? So I think there are certain inviolable, non-negotiable rights which cannot be subject to, the crass utilitarian calculus of felicity, and that people need to be at least given that information so that they can exercise those rights. They're inviolable in us, and I think that needs to be protected. And I echo what Dr. Subramanian Garu has said about this. Perhaps,
yeah, but would you want to explore a little bit more from this perspective? Like, what do you feel from especially as we set out to do the Sparsh Behavioral Lab, what could be some of the initiatives that start these conversations?
Yeah. No, I think, so we are in a hospital, and, death is not just a physical event. Death is a social event. And a hospital doesn't work in isolation. It's a social organization. It's an institution. And it impacts people not merely who are those immediately associated with the institution, but a wider set of people. And insofar as, building an institution is concerned, we do need to investigate the social norms, the normativity, the culture around this institution. And Sparsh is the first of its kind. It's one of the most remarkable institutions that I've ever come up. And it's an immense opportunity for us not only to acquire greater knowledge, but also use that knowledge in a very applied way to change things on the ground and to educate people in society. So Sparsh is much more, it's much bigger than what might appear on the surface. Sure. Right? So that's the so there are immense possibilities.
Dr. Subramaniam, like we talked about social norms and cultural taboos, and is there one thing in your experience as a physician as well as a trustee of hospice, one cultural taboo that if we could wave off or reshape that narrative, you think things would be different?
According to me, if you get over this letting go. So when we've seen at Sparsh that patients, when they're told by their physician that this is end of life, they don't want to accept it. Either they or their family, they'll go to another physician and end up spending a lot of money, chemotherapy, and then the patient deteriorates. So if you could trust, accept a doctor and learn to let go of further treatment, I think that is the key in coming early and having a better quality of life. So the patient and family members should get that in their mind that, okay, this is nature. At some point he's going, and that time has arrived. See, I can understand if some Ambani or someone who's loaded wants to prolong his mother's life or his life by giving $1 million a day. But for an average or below middle class income individual, it's a huge burden to try these experimental or non-working, and then it ends up debilitating the patient. And they don't realize that. Everyone thinks they have to do everything to prolong life, but they're not seeing to what end they're trying to prolong. Yes. So this letting go has to come. I think as more conversations happen, at some point people will understand that.
Maybe Radhika, would you want to shed some light on what are those cases where how do we start these conversations? Because it's difficult. It's hard to let go of someone you have loved, right? When do you decide? How do you decide to let go? What kind of conversation should begin, and who should be part of those conversations?
చావు కూడా పెళ్లి లాంటిదే, పెద్దవాళ్ళకే సెలబ్రేట్ చేయాలి. I think we should follow that, like in our regular conversations. We need to have, like, as we celebrate birthdays, graduations, weddings, everything, we plan it so well, meticulously planned. But when it comes to death, we don't want to talk about the death. You don't want to use that word death also. So I think what we started at Sparsh, proudly I can say, we started doing it in CAS programs at schools, which we started talking about death. So we need to start, building that at home, like talking about living well. Okay, what if unexpectedly something happens to me? Somebody should take care of it. Those are the conversation we should have it at home. And also, like Western countries, everybody has to write a will. Here, when we talk about will, everybody becomes silent. Like no one wants to write a will. And as we are talking about these advanced medical directives, we want to incorporate those advanced medical directives in corporates so that they know like what exactly we can just ask the parents or like anybody, like does it have to be parents? As Sir was saying about this patient autonomy, that should be incorporated in all our conversations. And like more it cannot be the regular family conversations. It should be ecosystem should be built in the system, like in everywhere. That's what, like, in that Sparsh we are trying. Our psychology department, social workers, they do counsel every day. I think the acceptance is the biggest
It's a huge challenge.
So these people every day they go and talk to the families and they explain, like, what, like, breaking bad news and all those theories they follow. But a lot to be done. It it's a community thing should be taken forward.
And maybe, Sharon, it would be great from, maybe behavioral science perspective, right? And US. I think having lived in US for some time, I'm familiar that people are a little bit more, maybe not so afraid of death. Like you said, your parents themselves prepared. They know, okay, we need to put things to proper closure and so on and so forth. And they will even have this conversation with their children. But in India, that doesn't happen. So, uh, from a behavioral, I mean, what do you feel is the reason why these conversations happen more naturally? Is it more cultural, or do you think is there something that needs to happen more from a societal perspective?
One of the values there is like individual responsibility, right? So it's coming from a framework of I'm responsible for what happens for me through the end, right? And so it's different than a situation where you're more cooperative and more family oriented and people share responsibilities, right? So it's almost like a division of labor, right? It's a different division of labor. And so while, for in this specific conversation and this issue, we want to move in that direction of, having more autonomy and being more responsible for your own decisions and what happens to you. We don't want to throw the baby out with the bathwater either, right? Like that, cooperation and family structure is so useful and so good in so many ways, right? So I think part of the challenge is kind of trying to navigate like how you change individually without wanting to change the family or needing, right? Without losing the family ties, right? I think that's part of the challenge.
So I think I completely agree with her. There's a lot of autonomy. In fact, when an American couple refers to their child, they will never say my child. They will say the particular name of the boy. My Harry came home late, but we'll say my son came home late. So that the importance of autonomy is a lot more in the Western world, and I think it's just inbuilt in that culture, and even in the medical practice. So there is no question of even a family member trying to shield, because the doctor will only speak to the family member. In fact, the family member can say, I don't want anyone else when you're speaking to me. And that is something which is very sacrosanct. And maybe we should work on our physicians as well to insist that that happens here.
Do you find anything different from gender perspective, caregiver? I mean, I hear a lot about caregiver burnout, and this is another area that we need to look at from a Sparsh Behavioral Lab perspective is, how are caregivers treated and what is their thought process? Or
Yeah, surprisingly, I noticed, like, we all know that, wives taking care of husbands is just pretty normal. When I came here, most of the, like, when husbands get sick, all the time the attenders are wives, caregivers are wives. But we get the request to get the paid attender or the companion if the wife is sick. So that gender thing is there. And also, if we ask the wife, why don't you just go home and put like your children here? And the wife feels so guilty. And like, she doesn't want to leave. And it's all, she feels like everybody else judged her, like, I left my husband there. And that gender thing is there, but maybe like, Samantha Garu and these social workers, they can add more into this. But overall, I know.
You feel that there is a gender difference. No, so interesting. So I think there are a lot of psychosocial, emotional issues that revolve around death and dying. And I think the first thing is just driving awareness and talking about it, right? And making it a normal thing, talking to your loved ones, understanding what their wishes are, and maybe normalizing this conversation, I think maybe is a good first step. And Pawan, do you want to add some insights to?
No, there certainly is a genderization of roles, and there's a lot of patriarchy. And this brings up problems. So, while on one hand, we do want to encourage the preservation of the family, but the family can also be a pretty nasty institution. Let's not mince words about it. The family is a wonderful thing. Without the family, none of us would exist, and so on. But families can also be highly exploitative, particularly to women in terms of the division of labor and so on, right? So, and daughters-in-law take care of their parents-in-law, but not their own parents in some sense. And so there's an asymmetry in what is owed to the older generation. So gender is a key part of thinking about the family. But there's another sort of deeply challenging issue with regard to the family when it concerns dying, and that relates to the cognitive load that is shared at the time of death, right? The process of dying is a very intense one, and it's attended by a lot of grief, and it imposes a huge amount of cognitive load on the people who are surrounding the death. And they can take a lot of bad decisions, particularly in terms of property matters, right? I know any number of people who have been systematically exploited right after death. So is there a way that we can advance the discussion of death, like Dr. Subramanian Garu has suggested, so that people are able to make decisions in a much more rational way rather than only at the time of dying or post-death? Right? During grief is a period of time when systems one kicks in. I mean, you have the dual systems of thinking. Systems one is the impulsive, systems two is the more sort of thoughtful, ponderous way of arriving at decisions. And systems one is the prevailing system of thinking, cognitive thinking, at the time of death. And that's not necessarily the best time of making decisions. And the family is afflicted by that. So by shifting it to a more individualistic form of decision making pre-death, you might actually mitigate so many of those problems. The decisions needing to be made by individuals. Now you might wonder, why should the decisions be made by individuals? We are a communitarian society. It's a form of social insurance. Now, why do we have this social insurance? We have social insurance because there is a failure in formal institutions. Right? So the failure of formal institutions leads to interdependence, and that interdependence leads to the strengthening of the family and so on and so forth. Whereas formal institutions in the more Western environments are much more robust, much more predictable. A legal case gets settled in less than 2 years, whereas it takes 30, 40 years here. So we have to necessarily depend on trust. We necessarily have to depend on social capital to mediate the transactions that we engage in society. So there are cultural differences, there are sociological differences. But if we can shift it, and I think Sparsh, so I mean, I keep coming back to this point, Sparsh has a much bigger role in society. It's not just a hospital which just takes care of people who are dying. It's a social institution. And that broad view is, I think, what we need to sort of explore and engage with. So that's the really sort of the profound and thrilling part about Sparsh.
So I think this was a wonderful discussion. We'll wrap up in the interest of time. Thank you so much. This is the beginning of the journey and the conversation. As you can see, it's a very deep topic as well as very broad, right? We can go into multiple dimensions. We can look at it from patient centricity, caregiver, the support structure, and so on and so forth. At Sparsh Behavioral Lab, we plan to address all of them. We plan to drive awareness. We plan to drive interventions as well as do deep research. This is the beginning. Thank you so much, all of you, for being here. I'll make sure that at Sparsh website there is a page for the Behavioral Lab, and you can reach out to me at any time. So thank you so much.